Exam 2 review. There has been a study guide posted in the course room. I'm just going to pull that up for us. The concepts that will be covered in Exam 2 are special vulnerable populations, pregnant adolescents, LGBTQ population, mental illness, alcohol, tobacco, and other drug problems, hospice and palliative care, death and dying, faith and spirituality, ethics, occupational health, environmental health, barriers to learning, and reinforcing health education. These are the readings that you can refer to. And in certain chapters, there are only certain pages. So just only refer to those pages that are listed. And these are your readings for each week. The exam will consist of 50 questions, multiple choice. Select all that apply. There will be some math problems. Please refer back to the math handouts that were placed in the course room. And of course, this is not an all-inclusive study guide. Best practice to prepare for the unit exam is to review the notes, the recordings weekly, review the readings and discussions. As we review for the exam, the postings will be listed. The recordings will be listed from each of the professors. So be on the lookout for those. Okay, let's go ahead and just look over the content that will be covered in Exam 2. The American Nurses Association, they formulate general guidelines for nursing practice. And then from those guidelines, the different places or entities, they develop their policies and procedures. But the American Nurses Association guidelines are they're broad. They're not specific. And you also, once you become a nurse, you can also become a part of this association. And they have many resources available for you as a member. But the American Nurses Association, they have formulated general guidelines for nursing practice as a whole. And then from those guidelines, the different places, the hospitals and nursing homes, the different healthcare facilities are the places that provide healthcare. They develop their policies and procedures from these guidelines. But these guidelines are very broad and general. Vulnerable populations, remember, as you read through your questions and determine which answer to select, you want to consider who the population is. Are they vulnerable populations? For example, are they homeless? Do these people have a certain disease process already in place? So these are things that make people vulnerable. So consider that when you are selecting your answer choice. But vulnerable populations often have poor health outcomes compared to other people. These groups have a high prevalence of chronic illnesses. So the vulnerable populations, many times they cannot, or for one reason or another, get the healthcare services that they need. So that's why you would see them with the high prevalence or rate of chronic illnesses, because most of the time it is later on when that disease process has been in place for a while before they actually seek out or can get treatment for that, because of them being that vulnerable population, whether it's related to social economics, not having a job, not having somewhere to live. We do know, like with migrant workers, they have those crowded conditions. So consider that the population. Pregnant adolescents, they're more likely to engage in sexual activity without birth control and under the influence. Pregnant homeless teens present several challenges. Remember, this person is not an adult, and they are homeless, and more than likely they probably do not have healthcare insurance or the resources that they need in order to be able to take care of themselves. So you will see the high prevalence of disease processes, whether it be elevated blood pressure, positive STD tests, However, most concerning would be homelessness, as homelessness presents many challenges for women during and after their pregnancy. Postpartum visits with the teenage mom, the primary goal would be to assess how much the mother knows and understands. And then you can provide that individualized care. You can ask those open-ended questions to see what they know and understand, and then move forward with deciding, what things or what resources do you need to try to make available or make that connection with for the person, for your patient. So mental illness and anxiety, mood, and eating disorders, they have a high risk of homelessness. Substance abuse users, they have, a high risk of being homeless. General anxiety disorder is a person who experiences persistent, unrealistic, or excessive worry about two or more life circumstances for 6 months or longer. GAD, or general anxiety disorder, usually develops slow and is chronic in nature. Patients with GAD worry more than what is considered to be average. At some point, we all worry about things, but it's like when it goes beyond, the worrying goes beyond, and here we say for 6 months or longer. They often worry about multiple concerns at a time instead of feeling anxious about one particular issue or circumstance. Remember, a person with phobia experiences excessive, irrational fear of something or situation. And the key point is irrational fear. Someone that has, afraid of a cup or spoon or water, things that are not rational. Obsessive compulsive disorder, the person experiencing obsession, and as a result of they have that reoccurrent thought or action about whatever it is. Obsessive compulsive order experiences an obsession with recurrent or intrusive thoughts that they cannot stop thinking about. And that in itself can create anxiety. Post-traumatic stress syndrome is characterized by previous event that's involved threatening to life, limb, or eyesight. And the person re-experienced that, or because of that thought about that previous experience prevents them from doing things going forward. The remembrance of such events, they produce feelings of intense distress with anxiety. Sometimes these when people have PTSD and they experience that, they may think that they're having a heart attack, their chest hurt, they really have symptoms like something really is occurring. But it's triggered by the remembrance of whatever that event was. It can occur after something traumatic happening to them. Bipolar disorder is when a patient experiences episodes in extreme sadness, hopelessness, and helplessness. Bipolar disorder is characterized by episodes of major depression with at least one episode of manic or hypomanic. So you would see the behavior going from one extreme to the other. They may have periods where they don't sleep for, 4 or 5 days. And then on the opposite, hypo, they sleep for days and days and days. They don't get up and, do the regular ADLs or the regular rigmarole for, in life. And they just rather sleep, stay in bed for a couple of days. So you would see the both extremes. Bipolar disorder is characterized by episodes of major depression with at least one episode of manic and hypomanic behavior. So lithium and mode stabilizers are the most effective treatments for bipolar disorder. So you would need to do your teaching, and that teaching will include encouraging normal salt intake, normal fluid intake, advise them to take their medications with meals, because many times medications, if you take them with meals, it lessens or decreases the gastric irritation. It decreases the chance of them having diarrhea, nausea, vomiting. So substance abuse, alcoholism, is associated with vitamin B deficiencies and folate. So those are supplements that you would expect someone that has alcoholism to be taking, or that would be something that would be recommended. And that's just, usually over the counter. They can just pick that up over the counter. But someone with alcoholism, they would have those vitamin deficiencies, particularly folate. They will also have could potentially have a low magnesium or potassium level. And oftentimes you see that they are anemic. So when blood work is done, their hemoglobin and hematocrit would come back low. And they're prone for malnutrition because they many times skip meals, and because they're focused on that alcoholism. So they're not even getting the nutrients that they need from food because they're not actually eating the foods. Blood alcohol concentration is determined by the concentration of alcohol in the drink. The rate of drinking, the rate of absorption, usually food slows it down, and the rate of metabolism, and a person's weight and sex. So all those things are considered when we are talking about the blood alcohol concentration for someone. So, there would be a different concentration or absorption of the alcohol if someone is actually eating while they're consuming the alcohol. And if they're just casually drinking versus someone just, down and drinks as soon as they finish one. So the amount of alcohol the liver can metabolize per hour is equal to 0.25 ounce of whiskey, 4 ounces of wine, and 12 ounces of beer. So we have energy drinks, tobacco, electronic cigarettes. For electronic cigarettes, remember that the oil is poison to the children. So you have to be careful with vaping or using that those e-cigarettes around the children because of that exposure to the smoke inhalation. And also, you do not want the children actually touching the electronic cigarette themselves either, because it run the risk of absorption. So for cocaine use, it is associated with cardiovascular problems. Cocaine is a stimulant, and so it raises those heart rates and blood pressure. And so that, therefore, you will see complications related to the cardiovascular system. You may see people that are long-term cocaine users, that they may have had heart attacks, several heart attacks, and it's related to because it is a stimulant, and it raises, the heart rate, the blood pressure, because sometimes ingestion of that, it will require emergency attention. For death and dying, we want to provide comfort, remember the different stages of grief, and you want to establish that rapport and allow and to create that therapeutic communication flow with the patients and the family members. You want to ask those open-ended questions, and you want to identify your own understanding and beliefs about death and dying, and recognize that your patients and their family members may have different ideas and about death and dying, and you will have to respect that. I have a PowerPoint too that we're gonna cover some of these concepts into. So environmental health. Children are most vulnerable to adverse health outcomes associated with environmental exposures, especially chemical exposures. Remember lead, any buildings that were built before 1978 can cause developmental delays. If that paint is chipping, and the children are exposed to it and it gets absorbed, then it can cause developmental delays and cognitive deficits in children. So oftentimes when the children go in for their well checks, now they do a questionnaire, and then depending on the answers to that questionnaire, then they may do the lead testing. Up until a couple of years ago, it was like an automatic thing that they actually drew blood and ran those lead levels just to ensure or to check to see if those children had been exposed to lead. and what was their level of exposure, because that lead exposure can cause developmental delays and cognitive deficits in children. So when we're talking about education, you want to always ensure that whatever you're teaching is actually being received. Do your patient, are they understanding what you're talking about? Can they read the educational materials that you've actually given them? Have you established rapport? Because if you haven't established rapport and trust, they are not going to move forward with any of the interventions that you're recommending for them. So you want to identify to see if there are any barriers to learning. Are they able to read? Do they need an interpreter? Because if they can't read, you may have to change up the actual the literature that you have for them. You may have to get it in a different language. You may have to secure an interpreter. So you want to identify whatever those barriers are for learning. If there's something else going on and it's more important to what you're talking about or discussing with that patient, you want to identify that, because their focus is going to be on that, whatever that is, rather than what you're trying to teach them. And therefore, your teaching would not be effective. One of the most important learner-related barriers is low literacy. Nurses, we have to often deal with individuals who they just can't read. They haven't learned that. And so these individuals may feel embarrassed to admit that, but again, you want to establish rapport, establish that trust when you're interacting with your patient. And then they'll tell you, hey, you've given me all this stuff, but I can't read that. And they'll be more forthcoming to let you know. A client who is aphasic has difficulty expressing and understanding language. So if you are dealing with a patient that has had a stroke, and as a result of that, they have aphasia, you need to ensure that you're facing the client when talking to them. You want to establish that eye contact. You don't want to speak so slow that it sounds almost mechanical, but you do want to ensure that you're pronouncing the words correctly, and and that you're giving them an opportunity to understand and comprehend what you're actually trying to teach them. You might want to use gestures like head motions, hand signaling. You may want to point to certain things if you have some literature and pictures of things to reinforce what you're actually teaching. For occupational health, this is the set we will be working in settings where the occupation is occurring. For example, a motor industry, where they're making production, they're making certain parts or making food items. So you are working actually in those settings, and they'll have your space. And you, as an occupational nurse, you'll see various injuries. You'll have people that are coming in, they're complaining of a headache, and you'll do your blood pressure, and you see that the blood pressure is elevated. And you'll go into that, those different levels of interventions about the teaching and screening and detecting. And also tertiary, because someone comes in and they complain of a headache, then you take their blood pressure, and the blood pressure's up, and you go on into having the conversation, say, hey, you have high blood pressure? They might say yes. And if they do, well, are you taking your medication? So you might have to just do that reinforcement. And then oftentimes people fall, they trip, they sustain injuries with using the different equipment and things that they use in order to do their job. So you may take care of things like scrapes and cuts, sprains, and different things like that. We kind of mentioned cultural competency. We need to approach each client as an individual. You want to identify your own ideas and beliefs about things, and also realize that the person that you're taking care of may have different ideas, and you have to respect that. Adolescents are prone to mood swings as they try to adjust to many physical and psychological changes. So they're coming from that child going over to that adult. So you want to, they're adjusting. So you want to consider The PACE interview can assist in distinguishing the drug-free adolescent from who may be experimenting with drugs and requires follow-up. Parents, peers, and pot. Question the adolescent concerning his or her parents, the relationship with peers, and an attitude toward an exposure to marijuana. You want to ask those open-ended questions, but first you want to establish trust up front. Alcohol, automobiles. Question the adolescent concerning alcohol use and his or her driving record. You want to encourage them to put on those seatbelts. Don't consume the alcohol. You for C, cigarettes, you want to discuss their smoking history. Is there one? And if it is, which devices are they using? Trying to recommend the cessation to stop smoking. And then education, discuss the adolescent's attitude and performance in school. So now we will move over to this PowerPoint. And these are all still the same concepts, but they just are in a different format. Beneficence requires the nurse to do good. All choices for a patient are made with the intent to do good, the most good possible within those circumstances. This is a reasonable, you want to have a reasonable response in whatever circumstances. And an example of that would be ensuring adequate pain control. That's an example of beneficence. It requires the nurse to do good. Distributive justice concerns the socially just allocation of resources. So across the board, are we making resources available to everyone, no matter what, their background is, their ethnicity, no matter what type of job they have? Are we making resources available for everyone? Then it's up to them to use those resources. Advocating for insurance coverage of hospice services is an example of distributive justice. It concerns, making sure that those resources are allocated. Do no harm, non-malfeasance, to do no harm when possible, whenever possible. An example of that is avoiding intramuscular injections. Non-malfeasance, do no harm. Autonomy. Autonomy is our ability, the patient's ability to make decisions and have a say in the treatment and care that they receive. And we have to respect that. If a client wants to stop treatment, then we have to respect their wishes. Even though we might know that treatment would improve or help their condition, but still, we have to respect the client's autonomy, the ability to make their own decisions. So when someone is hearing impaired, you want to ensure that the person can see you speaking. You want to ensure that there's adequate lighting. And going back to see you speaking, you may want to position yourself or stand in front of the patient. And you want to pronounce or enunciate your words clearly, but don't exaggerate what you're trying to say in the lip movement, because then it may look or appear that you're saying something different than what you're saying. And you want to speak in a normal tone. If the client has a profound hearing impairment, you might have to use sign language or an interpreter. If the client cannot understand by reading lips, the nurse should try using gestures and writing notes. We want to remember therapeutic communication. Using restatements and repeating the main thought that the client expressed. This ensures that the nurse is listening and attempting to validate what the client has said. So you and the patient are talking, and you, the nurse, you restate or repeat what the patient has said. That assures, well, first of all, it helps you establish trust with that person, because then they realize, hey, you really are listening to them. And this validates them as a person. So therapeutic communication is patient-centered. You just focus on the patient, not you, not their family members. And the goal is to promote a greater understanding of the patient's needs, their concerns, and feelings. A stroke is a medical emergency. Some symptoms of a stroke include trouble walking, speaking. The person may have the one-sided muscle weakness where they're not able to use an arm or a leg. And I mean, you may even see the facial drooping. Face may feel numb. The jaw area may feel numb. Early treatment is key in trying to dissolve that clot that's blocking that blood flow. As a result of a stroke, a person may end up being aphasic. They have difficulty expressing or understanding language. So some interventions that we can use, we want to face the client when talking, because remember, they have difficulty expressing and understand what is being communicated to them. You want to establish and maintain eye contact. You want to speak slowly and distinctly. Use gestures to enhance words, and use body language, motioning your head up and down or shaking your head from left to right. You want to give the client directions using short phrases and simple terms, and allowing them opportunity. If there's a need to repeat something, the nurse should use the same words the second time. Don't change up what you're saying. Then they're still not having a chance of understanding what you said originally. So there is no need to repeat something. If there's a need to repeat something, you should not change what you originally said. Psychomotor learning is the relationship between cognitive functions and physical movement. So having the necessary ability, so the thinking, the problem skills, the problem-solving skills, and also the physical ability to do. So it's a relationship between thinking, the thought process, and problem solving, and moving. Discharge planning begins when the person is admitted. You have to be thinking, okay, looking ahead, what needs, or what is going to be this patient's, what could be this patient's needs when they go home. It might change, but thinking about discharge planning and starting discharge planning at the time of admission, it reduces readmissions and it decreases length of stays in hospitals. So discharge planning, it begins the time that person is admitted. When you go home, are you returning to your home, or are you going to stay with someone? Are you going to a long-term care facility? If the patient is needing oxygen, will they need that oxygen once they leave there? Do they already have oxygen at home? Or do we need to go ahead and start coordinating, seeing what resources are available in the community? So discharge planning begins at the time of admission. We talked about determining the ability to read and comprehend, and that can be a barrier for your teaching. You're sitting down with your patient, they're getting ready to go home, and you're giving them the discharge instructions. Usually we print out these forms and things for them to review. We have handouts, and they can't read. And so, and they may not initially tell you that, but you do want to allow the patient time to read, allow the patient to restate or to paraphrase what they have read, and allow the patient to do a teach back. So that will ensure whatever they read or you taught them, that they really understood it. Allow the patient to ask questions. And sometimes, there is some embarrassment because of that. So your patient may say things like, oh, just tell me what I need to know. I don't like to read. Instead of saying, hey, I really can't read that and understand, I need your help. Can you, record it, or can you just tell me what it is that I need to know? Explore. Lack of self-confidence, you want to ask those open-ended questions, and that will help you to establish that trust and gain more information from your client. Explore the patient's feeling, asking them who, what, why, how did that make you feel? You want to explore, because sometimes, someone has a disease process going on. They just lack the confidence. They're already feeling down about whatever it is. And so you want to be patient and then ask those open-ended questions so they have an opportunity to inform you of what's going on. Occupational health nurse, you're going to encounter various injuries and diseases that the person acquired, while at employment. We spend a great deal of time at work. So, you want to ensure that you think about the whole person. Like the example that I gave earlier, the person's coming in with a headache. You check their blood pressure. You find out they have high blood pressure, and they may or may not be taking their medications. They may have run out. So be thinking of those resources and things, the education, telling them, how important it is to comply, to do those self-checks at home, and to take their medications. You want to conduct an assessment of the workplace itself, because that in itself, while you're conducting the workplace assessment, you can identify some things, some potential hazards. You keep getting these people coming in, they're falling, tripping over things. So you taking that workplace, that work site tour, you may identify, well, hey, this rug or whatever this is, these boxes stacked up, they don't need to be there. And then you can go back and make those recommendations about things that you think needs to be changed in order to, decrease the injuries on the job. That direct observation allows you as a nurse to learn more about the work processes and the materials. What is required. The person has to do this and then go to this station and do that. And so it just allows you to gain more information so that you can recommend planning programs, come up with your teaching programs for the month. American Nurses Association standards of care. We did say that they provide a foundation for healthcare facilities to create their policies and procedures. Their standards are broad, and so, but we do know that the other policies and procedures do rest upon this. They are authoritative statements that describe a common or acceptable level of care or performance. And so this is the standard. At a minimum, this is what we expect. And then that individual healthcare facility, then they develop their policies and procedures, but they can't, not meet that standard of care. They are broad and general in nature, and they apply across the nation. And you yourself can become a part of that nurses association. They have many resources. Ethics committee tasks. Sometimes you'll be called upon to serve on an ethics committee where you work, and you will be going over ethical dilemmas, provide education, provide recommendations for policy changes. And as that facility might have cases brought on by their people that work there, or the people that they're providing care to, you may be brought in on that team to review what actually happened. So that's that case consultation. Cultural competence requires individualized approach for each client. You want to gather data on their beliefs and what they expect and their expectations. We do not treat every client the same, nor do we treat them the way that we want to be treated. We want to acknowledge the cultural differences, understand our own culture, and come up with that individualized approach, because each person is different. E-cigarettes, we did say that children are at risk for poisoning, so they should not come in contact with that oil. They should not handle the e-cig devices themselves, because the potential for absorption and ingestion is there, and we do know that it's poisonous. They can also have lung damage if they're exposed to that secondhand vapor. Blood alcohol concentration is determined by the person's weight, their sex, the rate of metabolism and absorption, the rate of drinking, and the concentration of alcohol in the drink. And we do know that alcohol that can alter our judgment, our balance, the things that our vision, our reaction time. Okay, I will share this PowerPoint. You all already have the study notes. And as the other exam reviews are made available, we will post those also. If you need individualized tutoring, please send an email so we can coordinate that. I did post some times and dates, but if those times and dates were not good for you, send an email so that we can schedule that.